I have great pleasure in welcoming you all for this interesting webinar organized by American College of Physicians India chapter, supported by unrestricted educational grant by Juventus. Today our topic is sneezing, COVID and beyond COVID. We have got good experts in the panel. Let me introduce one by one. Dr. Patabi is a renowned pulmonologist from Royal Care Hospital, Coimbatore. And we have the senior consultant ENT surgeon from Bangalore, Deepak Aldipur. Then we have Associate Professor Soumya from St. John's Medical College, Bangalore. And she is also a fellow, done a fellowship in allergy and clinical immunology. Right now, she is also treating COVID patients in our hospital, COVID ward. Then, last but not the least, my good friend, Suresh. Dr. Suresh Kumar is an infection specialist from the Apollo Hospital, Chennai. He is also treating COVID patients. So we have got experts. We got two ENT surgeons, one pulmonologist, and one infection specialist. Now we'll go to the topic. Today's topic is sneezing, COVID and beyond COVID. Why sneezing? Because everybody is aware and afraid of COVID. The moment somebody has got sneezing or cold, they call the doctor. Sir, can I test for COVID? So much of awareness. So I'll first go to Soumya. Soumya.
Yes, sir.
I know only 4% of COVID people have sneezing. Yes, but I see surprisingly 70% of the people with COVID have comorbidities, allergic rhinitis. Throw more light on this, Soumya.
Yes, sir. So there has been an extensive study in Europe of 417 patients. They found that allergic rhinitis was there in 70% of them, and 40% had asthma also. So there are a lot of people who have this coexistent comorbidities. And since sneezing is a part of allergic rhinitis also, patients very much get confused. They feel, okay, I have got sneezing now, maybe I have got COVID. Lot of telemedicine calls also are coming to us because of the sneezing itself.
But how do you differentiate the upper respiratory infections, different upper respiratory infections, influenza?
Sneezing can be because of several reasons. One of the most common reasons right now in Bangalore or anywhere in India also, it is spring. It is the flowering season. Lot of pollen is there in the air. This pollen itself can cause allergic rhinitis and sneezing. And also rhinoviruses, which cause common cold. That is also very common. That can also be causing the sneezing. Influenza can be there. And even coronavirus can cause mild cold. So it is important for us as an ENT doctor or a general practitioner to differentiate which is COVID and which is not corona. So
actually,
to differentiate...
go ahead.
To differentiate the incubation period, when somebody has got a common cold, it will happen in only 1 to 4 days. They will immediately start off with the symptoms. The symptoms will be very predominantly running nose, blocked nose, and then they will have some secretions coming out constantly either in the throat or from the nose. But in COVID, the running nose is not much. Nose block is not there much. Very minimal will be there. And common cold can be associated with throat pain. Throat pain is also not a feature, or pharyngitis is not a feature of COVID. COVID, especially the features are cough and difficulty breathing, both of which are not there in a common cold. So it is important for ENT doctors and for general practitioners to differentiate the two and reassure the patient saying, please don't come to the hospital, you're fine. Just take one tablet antihistamine.
Can I? Yes, sir. Sir, I would like to add one point to whatever Soumya said. Nowadays, we have realized this loss of sensation of smell, which is seen in certain subset of patients who can present with that. And many of these people are found to be COVID positive later. I think Soumya can throw a little more light on that.
Yeah, actually,
yeah,
Deepak, actually, the people will have loss of smell as well as loss of taste.
yeah.
So 84% of the people are complaining of loss of smell, and
Yes.
77% of the people have loss of taste. Soumya, can you explain why there is loss of smell in the COVID case?
So this is a very interesting point that Dr. Deepak has opened up. See, so, like you said, 84% have confessed to having some smell disturbances, and also some little or complete loss of taste also has been noted in 70% of the cases. Now, in autopsy specimens, when they have dissected, they have seen that majority of the concentration of the virus is in the olfactory bulb. And through the olfactory bulb, it has also spread intracranially to the basal ganglia, the lemnisci, the cortex. So there is a transneural transmission of this virus. This is something which is very important and probably can help in us trying to, develop vaccines for it or anti-neural medications. Probably it could be a research topic.
In fact, there is another theory. They say ACE2 receptors are there in the nose. So this corona affects those receptors. Probably that is also another reason. I don't know. This is one of the themes we suggested.
I agree with you, Dr. Murugathan. That also could be one of the possibilities. Yes.
Okay. Now we'll go to Dr. Patabi straight away, because now there's a lot of hype about hydroxychloroquine, Patabi, and recently they said chloroquine, there's a toxicity. So tell me about hydroxychloroquine in the management of COVID, and in general, any viral pneumonia, do you use hydroxychloroquine?
Okay, hydroxychloroquine has a very unique way of acting, and so there are a lot of bench studies which said that chloroquine and hydroxychloroquine are helpful in viral thing. Actually, the pathophysiology, how it purportedly acts, is that the virus goes into the antigen presenting cells, and then that goes further inside. And for COVID, the antigen presenting cell is a ACE2 inhibitor, that, like what you had already said. So it's that ACE2 receptor is where the virus sits, and from there it just goes in. And apparently the hydroxychloroquine and the chloroquine will interfere with the glycosylation of that particular receptor. So it downregulates that receptor, and hence, it supposedly prevents the virus from getting inside the cell. And the second way that it acts is probably when the virus gets into the endolysosome, it increases the pH, and hence it inactivates or decreases the multiplication of the viruses. So it supposedly acts in two mechanisms. One is preventing getting in of the virus, and also it kills the virus. So that's how it is supposedly known to act. And so there are very elegant studies done in the bench, and it showed that it actually acts both in terms of prevention and in killing. But subsequently, they did. Thanks to Trump's acknowledgement of hydroxychloroquine being a game changer, and ICMR following it up with, using it in prophylaxis, and so it got a lot of optics. It came out of just two studies. Both studies are very poorly done. One was from French study, another was a Chinese study. Both of them showed some mixed results. The French study said that it's absolutely, it takes care of the virus. It was a very, very poorly conducted study. Just about 42 patients were used. And the end point was not symptom relief or mortality. The end point was they did a PCR on the day one. They started the patient on hydroxychloroquine. Subsequently, they did a PCR on the day 6, and they found that people who were on hydroxychloroquine had a very good reduction in the PCR, so which means that they had a reduction in the viral load as against people who were just used as a control. Now, control were 16 patients, and active were actually, to start with, 26 patients. They actually stopped to 6 patients were kept out of the study, and they just said that 20 patients who were on hydroxychloroquine had reduction in viral load. 16 patients who were not on hydroxychloroquine continued to shed virus the end of 6 days. So this was the study. But if you look at the study carefully, the 6 people who were taken off the study, 3 of them went into ICU, 1 of them died. So those were excluded. So those were the patient who received hydroxychloroquine. So the endpoint was not very good. And there is now a recent study from NEJM. It was actually not a study which is published as yet. It is just submitted for a peer review, which said that hydroxychloroquine had problems. In fact, people who had hydroxychloroquine had higher respiratory problems than people who did not. Again, this is a very poorly done study. It was not a randomized study. It was a retrospective analysis. So I think we'll have to wait for some good randomized trial before we jump these things. It's in fact clutching the last straw because it's cheaper. It's relatively less toxic, and it's quite widely available. People are actually going gung-ho. But at the moment, hydroxychloroquine in COVID-19 is only given as it's actually experimental. It's not very clearly proven as far as the benefit goes.
In fact, Patabi, recent Lancet article says hydroxychloroquine is not that effective compared to the French doctor who has did a cohort study of 1,061 patients. He's for hydroxychloroquine, whereas the Lancet says not very good. But what is your take on the prophylaxis, the role of hydroxychloroquine in prophylaxis of healthcare workers and the people who are taking care of the patients?
Yes, sir. So if ICMR guidelines say there are 2 kind of people who can take prophylaxis. One group is the frontline staffs and doctors who are taking care of the patients, and second group is the people who live along with the COVID positive patients in the same house. Those are the 2 people who when asymptomatic, can take hydroxychloroquine. The dose is 400 BD on the day 1, and after that it's weekly 200 BD or 400 milligrams per every week for the next 7 weeks. Came again out of a bench study which looked at these things, but there is no data, and the ICMR also says that you may take it. It is again not very proven. It's again experimental. It's just based on logic than any hard scientific data. So answer is actually we will not know. So the important thing is to ensure that the wrong people don't get it. The wrong people meaning people who are not any of these 2, or again, even if they are any of these 2, people who have problems and who are prone for side effects. So for that, we need to know what are the side effects and how we have to be very careful. So ECG comes mandatory. You need to look at the QTC. You need to tease out people who are on antipsychotic or anti-epileptic. There are a lot of QTC drug interaction. So azithromycin, for instance, levofloxacin. Yes, sir.
Patabi, now Dr. Suresh has come. Dr.
Yes,
Suresh, Suresh, are you there, Suresh? Dr. Suresh? Hello, Suresh? Okay. He was there on the line because I thought Suresh.
Yeah, he's actually there. I don't know whether he's unmuted it or he's still there. I could see Dr. Suresh there.
Yeah, because Suresh is treating patients. Unmute.
I think we'll continue with Patabi till we have Suresh on.
Yeah, so it'll be interesting to get Dr. Suresh's perspective because I mean, this is a logic, but how would it? Yeah, sure. So we were just discussing about the toxicity profile, and so we need to be very careful about what are the medications he's receiving. Anti-HIV medications, fluoroquinolones. These are common medications that can be quite interacting with this, and so you might have a QTC prolongation. So they say if there is a QTC between 450 to 500, you need to repeat QTC almost a daily basis when you're treating with the HCQS. So I think there are a lot of issues, and that can cause a hypoglycemia. There are many issues with HCQS. So at this point, the jury is out. At this point, I think we'll have to use our due diligence. And then, all these trials have just shown that it's given very mixed signals. And one thing is very certain, HCQS is not a game changer as far as COVID is concerned.
In the meantime, Suresh, I think he'll join. We'll go to ENT. Soumya,
yes, sir.
We take the nasal swab, throat swab. How do you take the throat swab? And how do we send it? What is the transport conditions for sending the throat swab?
Okay. So for the diagnosis of COVID-19, the most important thing is to do an RT-PCR. That is the diagnostic tool. To do this RT-PCR, we have to get the sample. The sample will be a swab which is taken from the nasopharynx and from the throat. Now, the correct position of taking the swab is very important. The highest yield for the swab will be in the nasopharynx. So if you take a nasopharynx swab, the chances of us getting a positive test result is higher. But it is quite uncomfortable for a patient, for him to let the physician or the swab person who's taking the swab to put completely the swab into his nasopharynx. Hence, it was modified, and WHO told that we can now take a swab from the middle turbinate. So we can take a swab from the middle turbinate area, that will be by a professional, usually ENT or somebody who's trained in that, and also from the tonsillar area and the posterior pharyngeal wall. So now these are the accepted places for taking the swab. The swab, as soon as it is taken, should be put in a universal test tube, which universal carrier medium, a viral carrier medium, which is provided in the PPE kit for taking the swab. So this has to then be put in a plastic cover with a absorbable sponge cotton. And it is very important that the temperature is maintained between 2 to 8 degrees centigrade. At 4 degrees centigrade, the virus thrives well and it will not die. Hence, it's very important that the temperature is maintained, and it has to preferably be transferred to the testing center within 24 hours. And the person who's taking the swab should take complete precautions. He should be using a personal...
In fact, so Soumya, I'm very proud to say, in Tirupur IMA, we have developed our own method how to take the shield for the doctors, how to protect the doctors. Yeah, so we did that. We did that. And now, one more interesting, Soumya, I heard the nasal cavity and the sinus in the body, the temperature is very less compared to, I know only the scrotum, the temperature is less, but they say sinus and the nasal cavity also, the temperature is less. It's like air conditioned for the virus. So that's why it is there.
Yes, sir. The nose is an excellent filter. It functions as an AC. So it not only humidifies the dry air, which is coming in from the outside atmosphere, but it will also bring down the temperature of the air. During inspiration, the temperature of the inspired air will be around 30 degrees centigrade. During expiration, it is around 32 degrees centigrade. Whereas the human body temperature is 37 degrees centigrade. So you can see there is almost a 7-degree difference is there. No wonder that virus can proliferate there because of this coolness in the nasal cavities.
Soumya, are you sure it is 5 degrees less than the body temperature?
Yes, sir. There have been thermocouple measurements. Studies have been done. So during inspiration, it is cooler. During expiration, it is warmer. And it is because of this coolness of the air that we perceive our own breathing, because of the coolness, how it maintains the coolness.
Sir, I would like to add a couple of points.
Yes.
Number one, the swabs in a huge pandemic like this, the swabs cannot be taken always by ENT doctors only. We will have to rely on the paramedical workers. So my only advice to them is that they keep the swab along the floor of the nose, closer to the septum. That way they are likely to touch the middle turbinate or the nasopharynx. Because to really get ENT doctors always to take the swabs may not be a practical idea. Number two.
In fact, Soumya had one video which she wanted to show, but I thought she will explain. Okay, now coming to you are talking about breathing. I think ICMR has done a study, yoga and nasal resistance.
Yes,
Can you throw some light on that, yoga and also breathing exercise, Kapalapati, whether it's useful? And one more thing.
In our hospital, so I did a study, it was sponsored by ICMR. This was on the various breathing exercises and Hatha Yoga asanas in patients. So we did a randomized double-blinded controlled trial wherein we took 30 patients on each limb, and we saw those were patients with allergic rhinitis, without allergic rhinitis. And we also saw the air movement. We measured it by a rhinomanometry. A rhinomanometry will give us the objective measurement of the nasal resistance. We found that the nasal resistance improved in those patients who did yoga. So when I say improved, it has increased. When I mean it is increased, it means that it acts as an effective valve to prevent the spread of viruses or pollens into the lower respiratory tract. So yoga is very helpful. So that is an important, this was one of the studies that we did, but I believe that it could, since it increases the nasal resistance, it will also decrease the airborne pollen, the viruses, all that entering into the lungs.
Patavi,
Yes,
what about breathing? What breathing exercises in controlling overall respiratory infection? What is your take on breathing exercises?
Breathing exercises are useful first. Broadly, we would like to think it like this. You trying to induce the laminarity to a turbulent flow. We don't want turbulent flow because there can be micro shear at the level of branches, and so those are the ones that can cause or sustain inflammation. So to put it very simply, we think that the breathing exercises help in converting a laminar flow, a turbulent flow into a laminar flow. And, it goes beyond all this, and there are accompanying yoga, pranayama would obviously help in ways more than one. I can't really, put a finger on a single way in which it helps. We advise breathing exercises. Now, breathing exercises for asthma would be different from breathing exercises for COPD and bronchiectasis. So those are a lot more scientific thing. For instance, the bronchiectasis, we'll do a CT and then we'll find out what are the areas that are abnormal, and then we'll try to improve or mobilize the secretions much better in putting the patients into position, and also give positive end expiratory pressure using PEP devices like Acapella or Aerobica. So breathing exercises is entangled in every aspect of chronic respiratory illness. In acute situations, I'm not too sure. For chronic problems, be it asthma, for which yoga pranayama would help. For COPD, wherein a structured pulmonary rehabilitation has been shown to give a very good improvement. Like in end-stage ILD also, there is a significant role for a pulmonary rehabilitation, including not only breathing exercises, but regular other exercises, upper limb exercises, lower limb exercises, and so on. And in bronchiectasis, very clearly looking at how a breathing exercises along with percussion techniques and the positive end expiratory pressure techniques or PEP devices will help in clearing that secretion. So all the chronic respiratory diseases, breathing exercises do have a very significant role to play. And
excellent. One point, sir. I just want to make one point. He has made an excellent point. See, because on this webinar, there are people, the common lay people also have logged in along with doctors. I don't want to give them a wrong impression that doing yoga will prevent corona. No, it is not like that. It's important to note that chronic diseases, like he said, asthma or, COPD, all that, the lung reserves will improve, the nasal resistance will improve. So it is important for that people who have logged into this should not get misled, because there are a lot of common people, the general public also have logged in.
Yeah, and also
be misled.
Yeah. Sure, and there was a WhatsApp forward also which said that you hold your breath for so many seconds. If you can't do that, you have COVID. And they have at least 3 or 4 patients calling me up and saying that I could hold only for 15 seconds. Do I have COVID and so on? So there's a lot of humbug going around. So let us be very clear on that. Yes.
Yeah, yoga will not prevent corona.
Yeah.
Okay. No, these are all supportive measures for any respiratory infection. Generally,
that's true.
Not
that's
for
true.
COVID.
That's
because
true.
This is again beyond COVID. Now I will ask you one more question. What about steam inhalation? They say steam inhalation sometimes is good for upper respiratory infection. Anything to do with COVID for steam? Hot air.
Sir, technically speaking, this COVID, once you are COVID positive, I don't think this has a very big role. Not at all. Whereas in people in general, when we are going through a pandemic, if they're going to do these breathing exercises or yoga or your nasal douching or steam inhalation, should help like simple measures to make things better. I would say, using this itself would put away COVID would be a too far-fetched statement. It should make your nasal cleanliness better, the viral load a little lesser. Just mere steam or hot inhalations would kill the virus completely, would be a little too high an ask. I would like Soumya to comment on this as well.
So there is an
Soumya,
interesting...
Soumya,
Yes,
before
sir.
that, you are doing some ICMR things. How do we, it's a nasal cleanliness. I know they put jelly, it's a jala yoga. What is that?
Jala
Something,
Neti, sir. Jala Neti is a very
Jala Neti,
interesting,
yes.
it is a very interesting ancient technique of Indian tradition, wherein they put water in one nostril and they bring it out to the other. Now this Jala Neti will help in taking out the biofilm. Now biofilm for the general public is a membrane over which bacteria and viruses can grow. So by doing this Jala Neti, this biofilm is eroded, is taken away, and as a result of which the viral load will decrease. Of course, everybody cannot do Jala Neti. It's a technique, it's an art skill. But what they can do is we can use saline nasal sprays. Saline nasal sprays have known to improve the recovery time, even in common cold, in flu and all that. There is studies to validate this. So saline nasal sprays can be used, but to what extent it is used in COVID, it can help, we cannot really tell. COVID is a new thing. Nobody knows anything about it. So, you know.
Yeah, I think, you know, because Suresh is coming late, we'll continue with you. They say humidifier. So tell me, what is humidifier? Why do we use? And also one more thing, they say reduce the pressure room. Some, you know, what do you call that?
Negative pressure.
Negative pressure. Negative pressure. Yes. So can you throw some light on this, and Patavi can add Soumya?
So nebulizers. Nebulizer is one thing that I would ask people to use it with caution. See, people have home nebulization independent machines, or they come to the hospital to get nebulization done. During this nebulization, there is humidification, and also it moistens the nasal cavity. Sometimes the patient can sneeze. As a result of sneezing, there will be a lot of aerosol generation. This aerosol generation can spread to the bystander, and also the aerosol will be active in the air for up to 3 hours. So it is not recommended during COVID times to use a nebulizer. And coming to negative pressure rooms rooms are rooms specifically designed in the ICU or a place where a COVID patient is kept. In these negative pressure rooms, the air enters into the room. Then it is forcefully sucked out. All the air is forcefully sucked out of the room. So a negative pressure is created. And the only entry point for fresh air to come in will be from 1-2 inches space will be given. From there, the fresh air is driven in. This has to be done every 6 hours, so that even the healthcare personnel who are there are not rebreathing the same air, because the air which the COVID patient has breathed in or breathing out will have the virus in the air. So negative pressure suction rooms are very effective means, along with laminar airflow in the AC, to decrease the aerosol spread of the virus.
In fact, Dr. Muruganathan,
especially when you do bronchoalveolar lavage and all that.
Yes. So any aerosol generating procedure, the patient who has a COVID, people go to an extent of saying that if you have a OPD, it's good idea to have a negative pressure room when you're looking at COVID. Might be difficult. This is actually offshoot for, all these were actually relevant for tuberculosis and multi-drug resistant tuberculosis also. So you need at least 12 exchanges per hour. That's what is important to ensure that you keep exchanging the air, so you don't really have a stale air sitting there. So the exchanges have to increase from 12 to 15 per hour will ensure that you kind of take it out. Again, so when you have an oxygen, you have to add a humidifier. Even in the room, you can see that oxygen comes with a water. You pour some water, and so it just goes to a humidifier. Even that has to be stopped when you're treating these COVID seasons also. So any aerosol generating procedures have to be very careful. And that's why Dr. Soumya had told about nebulizer. It's ideal not to use a nebulizer. It's ideal not to use Venturi also, because all these becomes a high flow device then. Once it becomes a high flow device, we generate a lot of aerosol. So, sorry?
Patavi, I didn't get it. What did you say?
The Venturi in the air. So ideally, if you have to have oxygen, it's ideally given in the non-rebreathing mask. So there will be a plastic bag which will be connected, so the patient doesn't exhale a lot more, and so the aerosols don't escape a lot. So for a patient who's been admitted in a ward, if he has to be given oxygen, it's ideal to be given with a non-rebreathing mask also. So that would be, a rebreathing mask, so that he doesn't really expel a lot of aerosol outside. And he has to be nursed in a room which has a negative pressure. and ideally avoid nebulizers. And instead, you can ask the patient to take inhalers with spacer. You can increase the dosage, but use inhaler with spacer instead of giving them a nebulizer. So these are the things that can be done in the wards whenever you're handling patients with COVID. In a bronchoscopy room, again, that is another significant aerosol generating procedure. And hence, for all the bronchoscopy rooms, by design, we have negative pressure ventilation only. Otherwise, you'll have a tendency to have a lot of virus or an MD or tuberculosis bacteria hanging around in the air, so that you, for sufficient amount of time, that you can actually breathe. So in our bronchoscopy suite also, it is a negative pressure room. Now, if in the OPD, if you don't have a negative pressure room, at least have a cross ventilation. If you have a good cross ventilation and enough amount of air going across, then you are actually okay.
I would like to add a couple of points.
That is why even the doctor's chamber, nowadays we request that switch off the AC, then have open ventilation.
Yeah, open all the windows, so that you'll have one exit point and an entry point also. I mean, you'll have to have at least cross ventilation. That will be the...
Basically, sorry,
yes, Deepak, you want to say something?
I would like to add only 2 points. Number one is your, bronchoscopies or scopies ideally are done in theaters which have a very good air scavenging system. And number 2, the masks which you use, it's always better to use them with a bacterial filter or a viral filter which is personalized for each patient. So it is very, very important that your operation theater has a good lamellar airflow and a very good air scavenging system where the air is being taken away.
Yes, sir. We work in a bronch suite which is not attached to the theater, and so we still have a theater-like situation, and we use all the appropriate stuff, as you said.
I would like to elaborate on what Dr. Pattabhiraman said. See, there are now in COVID times, we classify all procedures as 2 things. One is aerosol generating procedure, non-aerosol generating procedure. So for every aerosol generating procedure, we have to use the highest level of protection. That is, the personal protective equipment has to be used. So which are these aerosol generating procedures? Like he already mentioned, it is bronchoscopy. From the ENT standpoint, it will be a tracheostomy. Then for the anesthetist, it will be an intubation. So all these, we should be very, very careful that there is not much of aerosol dispersal.
Even Soumya, these endoscopic sinus surgeries,
yes, sir.
We use the shavers or the microdrills.
But after oxygenation and medication, how do you manage respiratory failure?
Okay, so the patient has no. Actually, we all know that 80% of them they don't even get to the hospital. And people who get into the hospital, bulk of them will have oxygen and supportive medications. They usually get better. Now, if there is a worsening of oxygenation, what do we do? So we right away shift the patient to the ICU. So a progressive respiratory failure is the most important reason why the COVID patient gets into the ICU. Now, there is a via media between oxygen and ventilation, which is a non-invasive ventilation. So there are different problems, unique problems because of NIV and HFNC. So both these are high flow nasal cannula versus non-invasive ventilation. Both of them produce a lot of aerosol. So there has been concerns about whether we need to bridge it with an NIV or go ahead right away with an early intubation. If you use a NIV with a ventilator setting where there is both inspiratory and expiratory limb are taken care of and circuit is closed, and if you have a helmet instead of just a oropharyngeal mask, you'll tend to use a less of aerosol. So that is quite okay. You can technically use an NIV. If not, you just go into the ventilation. Now, if you have a hypoxemia, which is not corrected by oxygen plus or minus NIV with a due diligence, then we'll have to look at the intubation. Now, intubation, as Dr. Soumya said, is one of the most important aerosol generating thing. Now, the intensivists is in direct contact when they do an intubation. There have been a lot of hoods that have been described, glass hoods through which they do it. But still, it's still a aerosol generating, and you have a direct thing. So the most important thing is the PPE. So everyone in the ICU who is taking care of COVID patients should be with a complete set of PPE. There is no point in having just a 3-layered mask just in a N95. You just have to have the whole set PPE, and then you'll have to go ahead with a ventilation. So once you intubate and ventilate, now you will have there have been 2 kinds of patients that have been described. It might get a little technical here. So what they say about ARDS or respiratory failure in COVID is that some of them have a normal compliance. Now, ARDS by definition has a low compliance. And so we have a certain way of ventilating them, which is low tidal volume, high PEEP or an optimal PEEP, and prone position and so on. In COVID, based on, I have, the disclaimer is I have not treated one case so far. So that is the disclaimer. But this is based on our friends and the reports that we see. We see quite a significant amount of people who have a normal compliance respiratory failure. And the proposed theory is that it's more of a micro thrombus and micro emboli that is causing more a vascular kind of an hypoxemia rather than a interstitial and a pulmonary edema, non-cardiac pulmonary edema, which is causing this. So we'll need to ventilate these patients with a lower PEEP than normal. The PEEP is peak expiratory pressure, that the end expiratory pressure that we usually use, which is usually high for a regular ARDS. In COVID, we're supposed to use less of a PEEP and keep supporting till the patient improves. So generally, it's a good amount of supportive care. That's all that we can do. And hope the virus goes off and the patient gets better.
Sir, Dr. Pattabhiraman, even the
specific ventilator strategy you have? So 1 minute, Soumya. Any specific ventilator strategy you have for COVID patients?
Once you intubate the patient, you'll know whether the compliance is normal or compliance is low. If there is a low compliance, you go for a regular ARDS ventilatory strategy, which is low tidal volume. 5 to 6 ml kilogram body weight will be the tidal volume, and PEEP will be increased to the point where you have a good amount of flow that's happening. So that's a regular ARDS thing. And we also look at early proning, because proning will help. Yes. Proning is just, instead of ventilating the patient supine, you tend to put the patient prone. Interestingly, in COVID, while the patient is on oxygen, a spontaneous or breathing proning has also been tried. We ask the patient to kind of prone themselves with the oxygen on. Some people have a dramatic improvement apparently. Why does proning help generally in ARDS? Because when you lie down, the dependent areas go for an atelectasis, and due to pressure, because of the heart also, the left side, the lower lobe gets less ventilated. And so when you just switch the patient over, there is a lot more of air units that get open, and the heart's pressure is not on the left side of the lung, and so there are more lung units that can be ventilated. So it's one of a salvage procedure like a PEEP. And so here, proning is a labor-intensive process, and in an ICU which is not very geared up, I think they can't really do it. But if you have enough number of people, proning can be tried as an adjunct to the ARDS, which is yes, sir.
Suppose the patient is conscious and you are doing non-invasive therapy, can we ask the patient himself to go for prone?
Yes,
position?
sir. Yeah, self-assisted prone can also be done even in the room or in an ICU when the patient is receiving. Even on an NIV, some people have tried doing this with some good benefit. So if the patient can prone even without a ventilator, and if the oxygenation gets better, we'll just leave them doing that. Again, disclaimer: we've not treated a single patient, and so I think we will probably have to take that as
Soumya, because Suresh has not come, you are a ENT person. Tracheostomy, normally tracheostomy is done by the ENT people, we call for them. What do you do? Is it the open tracheostomy or subcutaneous tracheostomy, and what is the thing what you want to do?
So tracheostomy is a very high risk procedure. First point. Second thing, it has to be done with proper donning and doffing of the PPE. Percutaneous tracheostomy is a little less invasive than an open tracheostomy, and it is, if possible, it is advisable to do a percutaneous tracheostomy in these patients. Also, it is not, the only reason we want to do an early tracheostomy is to prevent the incidence of tracheal stenosis. So usually we try to do a tracheostomy in 7 days. But studies in China and Europe and other places have seen that it is okay to keep them on prolonged ventilation even for 2 weeks to 3 weeks, and later on to do a tracheostomy would be useful both for the patient and the doctor, because the doctor of the aerosol, and the patient also for the recovery phase, it would be helpful. So I would suggest that doing a percutaneous tracheostomy is always better than doing an open tracheostomy.
in general, see, in my town, one of the IMA president is a ENT person. He used to call me, what are the normal precautions an ENT doctor should take in this COVID times? Because many people this summer, they take ice cream, cool drink, they get cold and they come with sore throat. So what are the precautions an ENT physician or a surgeon should take before they examine the patient?
Okay. First of all, we have to divide the ENT doctors or the general practitioners into two categories. One is somebody who sees a general OPD with minor patients who come with minor ailments. Another is somebody who sees patients who are a little more sick, so that there is no mixture of the patient. Suppose even in case there is a suspected COVID present. In the OPD, using a N95 mask would be prudent. Now, N95 will prevent the entry of organisms less than 3 microns. The COVID virus is 12 microns. So N95 is very useful. The second thing is we can also use a visor. A simple visor, which is not very expensive, which also can be made using OHP sheets, is available now for 100 rupees to 200 rupees, and which would be very useful for an OPD setting, because it will prevent, it will minimize the doctor touching his face and nose. And repeated hand washing. Repeated hand washing has to be emphasized. It has to be religiously done. If it is not possible to get up after every patient, at least using sterilium or hand sterilization, and then afterwards washing the hands. The more number of times we wash the hands, the faster the virus, which is a lipid, will go away, because the virus is a lipid and soap is an alkali. So the two cannot get along. So hand washing is very important. I would not, there has been no recommendation for using PPE in the OPD. When you just have some simple cases which come, there is no recommendation as such now, but there should always be a suspect area, a screening area where PPE is mandatory and every doctor has to wear it.
I would like to just add a couple of points.
Yes, Deepak, you add.
Sir, generally in the regular ENT OPD, it is better to have 3 layers. That is, you have a regular mask, you have an N95, and if you see in these HIV operation kits and HBsAg operation kits, we get a mask with a hood, which has a film which is covering quite a height, This 3-layer protection with, as Soumya put it, frequent hand washing should be very good. And every patient who enters your room, if not with the attendant, should be given the disinfectant with which they wipe their hands first and get in. And with every patient, you use a disinfectant. That's very handy there. And of course, washing every 20 minutes helps.
Soumya, you are talking about N95 mask. I have 2 questions.
Yes, sir.
Can you reuse N95 mask? And generally, now the cloth masks are advised. What is your opinion about cloth mask, and how do we reuse N95 mask?
Okay. So before I answer this, I'm very happy to see that we have 1,900 people who have logged into our session. So that is very nice that people are interested to learn about COVID. That is one of the indicators that, people want awareness. I can see that both general public and doctors, both mixture is there. It is nice. Coming to the masks. So the masks, the surgical mask, the N95 mask and the FFP, these 3 can effectively prevent the entry of virus entry up to 3 microns. So they're almost 95% effective. The cloth mask is not as effective. In fact, it cannot prevent the virus coming in. But still the government and WHO, everybody has been asking everybody. First, earlier WHO said no need of everybody to wear masks. But now they have changed the stance and they say that everybody should wear a cloth mask. That is the general public. So how this cloth mask helps? 40 to 50% of the patients can be asymptomatic carriers. Asymptomatic carriers because they might have been earlier affected by a very weak strain of coronavirus. Coronavirus has got 6 strains. Not all of them are very fatal. Only one of them, the COVID-19, and then there are other related viruses like the MERS virus and the SARS virus. These are fatal viruses. So probably a patient has been affected by a weaker strain of the corona and has got immunity. It is possible because of that. And also there could be some in whom the immune mechanisms have not been kicked off, like the cytokine storm. So they are asymptomatic carriers. These asymptomatic carriers roam around. They might be delivery boys of newspapers, or they might be in the grocery store. So when the general public is going there to these places, it is important that they wear a mask for their own protection, because if somebody is sneezing, although it might not completely protect them, to a certain extent it acts as a barrier and prevents the aerosols from coming inside. So wearing a mask is a very good idea. It is one of the aspects of social distancing. And battling this COVID thing is nothing but an experiment in social discipline. How disciplined we are.
Soumya, in this juncture, I would like to ask you, many people use only kerchief. And when they sneeze, when they cough, Patavi, they put the kerchief and then sneeze. And they put the kerchief back in the pocket. Again, they use it. Do you think it's good? Patavi, what is your
opinion? Yeah, so it's better to use a tissue and then throw it, dispose it responsibly. I just like to add to what Dr. Soumya said. So if you have to have a cloth, it has to be cotton only. Cotton has some protective effect, but not the other things. So you have a cotton, homemade mask that's still about 50 to 60% effective is what the latest recommendations do. When you have a kerchief and then you sneeze on a kerchief, and then if you are unfortunately a COVID person, you're putting back on your thing, it stays there for some time. So as soon as possible, you try to do, wash it and do it appropriately, disinfection, and so on will need to go. So the best thing would be to, have a tissue and then, discard it responsibly. Sneezing without a cloth, you can even sneeze into a cloth or cough into a cloth on the elbow, creak and so on. The fiber fabric will actually desiccate the virus, and it will stay for some time before it goes on. The problem is, since there are a lot of non-medical people also, there are two things that you need to understand. When a patient coughs or speaks or sneezes, he can actually discharge. Now, the droplet nuclei comes for some distance and then it settles down. It stays in there only for some time before it settles down. So if you are within 1 meter, because they say when you talk, it just goes to less than, less than a meter. In fact, half of it just falls down. If you cough, it can go up to say 1 meter. So that's the reason why the social distancing for at least 1 meter is important, because the virus will not go and directly hit your nose or goes into your fomite and you can spread to others. So 1 meter is very important. And again, when he coughs, he can cough into a desk or into any other fomite. And that's the reason why, apart from your hand washing, you also have the secretary to very frequently come and disinfect your tables and the doorknobs and so on, so that it becomes fomite free as far as possible and as fast as possible. And as far as the reuse of N95 mask, for people who are uninitiated, N95 mask is a very higher, it has a higher protection from the viruses and a lot of occupational deaths. So when you use an N95 mask, so N95 mask, it works not only about mechanical. It's not only mechanical. It actually has 3 layers. The inner layer will have something that can prevent all the humidity. The second layer, which is the most important layer, which is filled with, there is a polypropylene material, which with a lot of electrostatic forces. These electrostatic forces are the ones that actually help in reducing or negating the viruses, and by absorption and the different mechanism. And there is an outer layer. Now, when you use an N95 mask, it has to be used when there is a significant amount of viral load. In a direct, for the people who are in the front line, in isolation, in the fever clinic, in the bronchoscopy room, in the ICU, and in the isolation room. So all these people will need to have an N95 mask, because it filters 95% of the viruses. If it does at least 95% of the times, you don't really have the things. And all these areas will, along with the N95 mask, we have other personal protection equipment also. Now, the problem is, in the pandemic, we are finding a significant shortage because the public is using it. For the sake of public, N95 mask has no meaning when you use it in your own thing. So I would strongly discourage all the public to, kind of hoard this N95 mask, because there's absolutely no use. For you, cloth mask helps very good, or a surgical mask or a 3-layered mask is good enough. or an N95 mask. I mean, N95 mask has no meaning for a general public, because that is the reason why the healthcare is also getting a shortage in that. So when you use a N95 mask, ideal thing will be every day you'll have to use a new mask, but that's not happening because of the cost and availability. And hence now there has been a protocol for reusing N95 mask. How can you reuse? You cannot put the N95 mask in sunlight. The ultraviolet rays also is mixed, and it can actually interfere with the electrostatic property. So you can actually put it inside a paper cover and keep it in a place which is dry, and for 3 days, 72 hours, and after that you can actually use it. So if you have 4 N95 masks, you will have to mark it as 4 paper covers, and then use it as Monday, Tuesday, Wednesday, and Thursday. And then you keep having it so that you use the first one, and then end of the day you just put it in the paper cover and store it in a clean place. You can use that after 4 days. So you can actually recycle, and this has actually been recommended even by the AIMS, and there has been a guideline for this. What are the other ways in which you can do? There are actually different kinds of things. Some people use oven. Some people use it even in a cooker with 120 degrees dry heat without adding water. So all these are available, but the best thing for medical professionals is to have 4 ones and can be used, and each can be reused up to 5 times. So up to 20 days, we have 4 masks you can use up to 20 days on the trot without significantly affecting the the efficacy. You'll have to have very important things. You shouldn't really damage the N95 mask. The most important thing is the electrostatic property should be intact. For that, you'll need to be very careful. You cannot use an alcohol. You cannot use a alcohol scrub. You cannot use a soap and water solution and then clean N95 mask. It doesn't help because it will lose your thing. Yeah.
In fact, Patabi, I saw in one of the picture, they put day 1, day 2, day 3, day 4.
Yes. That's what I said. Yes. Yes.
And sir, I have one thing. Yes, I want to make some just to elaborate on what Dr. Deepak Haldipur was telling earlier. Now, this is for the general public. There's a World Health Organization webpage which says Mythbusters. There is so many myths and a lot of WhatsApp forwards. And since I am also on telemedicine, I get a lot of calls from patients. They ask me if I put a hair dryer, blow it into my nose, will the virus die? Okay, if I drink hot water, will the virus die? If I drink alcohol, will the virus die? So there are several different things because of all this WhatsApp forwards, eating lemon, drinking ginger
and
tea.
Chinese tea, green tea,
Chinese green tea. So
perfect, yeah.
Yeah, steam inhalation or blowing hair dryer into nose will not kill the virus, because a virus requires 60 to 65 degrees centigrade for it to be killed. And by the time you do it, your tissues only will get burnt out. The second thing, 70% alcohol is what kills the virus. Now, you cannot drink 70% alcohol because your entire esophagus will have perforations along with your stomach. So the general public should kindly refrain from doing such things. Also, there is no evidence to show about tea. But of course, you can drink Chinese tea, you can take vitamin C, all that, because it has got no harmful side effects. But do not do things which might cause adverse problems, side effects, or risks for your own body. This is to educate the general public.
Exactly. And 70% alcohol is not good.
Yeah.
I don't know about the virus, but
I would like to add a couple of points. For the general public, the simple mask that we get, if they can wear 2 of them together, that is protective enough. The simplest mask which you get in the market, the disposable mask, if they can wear 2 of them together, that gives reasonable protection, number 1. Number 2, let the mask be a tight fit. When you breathe, if the mask is ballooning in and out, that is far more effective than one in which you are breathing easily through. This for the general public. Like, for example, when we wear an N95 in a proper fit, it inflates like a balloon. You can't breathe through it. So 2 simple masks which we get in the market, the ones which we use in the operation theaters, the simple ones which you used to use, you try using two layers together, that works very well. This for the general public.
Yeah. Patabi, what about fluid therapy? In some say, give good fluids, and some say, you must be very careful about fluid. What do you take on that? You are not audible, Patabi.
Am I?
Now you are audible.
Yeah. So fluid in ARDS has always been a debate. There are liberal people and there are conservative people. Usually we'll have a slightly on the liberal side, which means we give a little more of fluid than is usual, because when a patient is on a ventilator, you have a lot of other issues, including a insignificant loss and fever, and all these can reduce the increase the reduce the fluid in the body, and so we'll have to replenish it. As far as COVID goes, people all over the world are now advocating not a very liberal fluid. Don't try to fill the patients. So try to be on a slightly negative or an equal balance is what they're just saying. So the output and intake should be kind of matched. They don't want you to be very, make you very positive in terms of fluid balance. And they've said that there are a lot of issues with liberal fluid therapy in COVID. And so, again, as in any other thing in an ICU, the wire media is usually the right approach. The right approach is to have an adequate fluid. Do not allow fluid depletion because the shock might worsen. At the same time, do not give a lot more of fluid than what is required. A slightly more conservative approach is what has been recommended in the COVID situation.
And in this connection, what is the use of lung ultrasound? Lung ultrasound,
Yeah, lung ultrasound. Ultrasound has been, traditionally ultrasound was done and people thought that lung is the biggest problem in ultrasound because the air is a very poor conductor of ultrasound thing. And so there will be a lot of reflection, and hence lung is a very poor thing as far as ultrasound goes. But what they've done is air acts in a certain way once the ultrasound is passed, and it causes what are called as an artifact. The science of ultrasound in the lung is developed by using all these artifacts and making sense of these artifacts. So when the lung has a lot of air, it just reflects it back, and it doesn't give you a good image. But once there is a fluid inside, if there is a pleural fluid as a good covering between the lung and the chest wall, then you get a beautiful image. That is in pleural effusion, you get the fluid is very clearly seen. So if you have a fluid overload with a pleural effusion, you'll know. Or if you have a coexisting, pleural effusion, you'll know. But again, if there is a fluid in the lung, like in a pulmonary edema, you have, B lines, and those are the things that can be easily identified. So when you have a pulmonary edema, or when you have an air bronchogram in a pneumonia, all these are eminently seen by a lung ultrasound. So the biggest advantage in ultrasound is that you don't need to go into a CT to identify most of it. So you don't need a CT, you don't need a patient to be shifted out of the room. A point of care ultrasound is eminently doable. So a focus is what they say, point of care ultrasound. That has actually swept the pulmonology in many ways. And now what has happened is focus is useful in COVID because if you don't want the patient to be shifted out for other reasons, and hence if you have an ultrasound and you can identify changes that happen in the lung very early, and we can also follow very frequently. And so the most important thing is to taking care of the disinfection of the probe, which can be used by using a cover of plastic cover.
In the COVID times, Patavi, you'll be getting a lot of asthma, COPD. Is there any difference in approach or investigation, or how do you approach your patient?
Yeah, so there are issues actually. Yeah, the first important thing is when the patient has an asthma, and if he exacerbates, we do not know whether it's COVID-related exacerbation. So those are the things that we'll have to be very careful. So for a investigation's sake, we traditionally do a pulmonary function test. Now, pulmonary function test is another area where you can have actually a patient soiling all the PFT instrument, and the subsequent patient also using the same system and can get infected. And so the both the peak flow and the spirometry has been we are not using it unless we are very certain. So PFT is one investigation we would like not to actually engage too much with as far as the patient goes. And as far as treatment goes, we tend to use more of a meter dose inhalers than a nebulizer as an IP setting. Otherwise, in the OP setting, the patient goes back. I think there is no big difference in terms of COVID and a non-COVID, both in asthma and in COPD. Again, in interstitial lung disease, we do a diffusion lung capacity. We kind of not do that anymore as a follow-up. We use a 6-minute walk test, if at all, that we need to use it. There is a even a slight chance that the patient can be having asymptomatic or a early symptom COVID, we don't really get the patient into the pulmonary function lab. Again, as far as treatment goes, if there is in the COVID situation, the patient has COVID plus, meaning COVID along with a baseline problem for which he's on some medications, then we'll have to look at all the, interactions. And I think there is one question here about azithromycin along with the hydroxychloroquine is a combination. Actually, the French study which looked at this particular combination said that if you have azithromycin and hydroxychloroquine, which actually was in only about 6 patients, all of them had a reduction in the viral load very early in its, I think the 3rd day to 4th day itself, the virus kind of disappeared. However, both of them have a tendency to have an interaction, especially the QT prolongation. So you'll have to be very careful, use this ECG, and if the QTC is less than 400, you can give a combination. If there is a 400, 450 to 500, you need to keep monitoring on a regular basis. Beyond 500, it will be very, very brave to give these two together.
There are a lot of questions from audience. Dr. Varun Malu is asking, is nasal packing for epistaxis also an aerosol generating procedure? So I would like to take this question up. See, any nasal procedure has been classified as high risk. Nasal endoscopic procedures are very high risk. So kindly wear adequate protection before doing this.
And most important, preferable to avoid suction.
Correct.
That is important. Preferable to avoid suction or any instrument which has a rotatory movement. More to stick with manual movements. If you're doing nasal emergency surgeries like CSF leak repair or whatever, use manual instruments. Try to avoid the shaver or the debrider at any cost. Try to avoid the drills unless they're absolutely required.
Actually, there are a lot of questions have come.
Yes.
But unfortunately, the time is up. But we missed Suresh because we had a lot of questions for Suresh. In fact, they are trying the plasma now. In Kerala, they have given the permission for the plasma.
Yeah.
And one point about that, the patient was discharged 2 times negative. Then 3rd time also they do the check and check the antibody level. If the antibody level is IgG is more than 640, then only they take the plasma. That is the rule. But they are trying, they are getting approval for Tamil Nadu also. And then now they are doing and this monoclonal antibody, tocilizumab, that is an IL-6, the cytokine storm, that's very effective. So Suresh was telling me his personal experience. By adding those drugs, the results are very good. So I'm very sorry now, Suresh, we are missing. So we'll wind up. Now tell me, Patari, 2 important drive home messages, and then we'll ask everybody.
As far as COVID is concerned, the drive home message is the social distancing and wearing mask all over. I mean, I think these are the 2 things, and having a personal protective things, because the treatment has essentially been supportive only. All the medications that has been tried so far, be it HCQS, be it convalescent plasma, be it the antiviral, anti-HIV medications, or even anti-IL-6, all of them has not been proven conclusively. All of them have been useful adjuncts, but people get away even without that or go down despite that. So I think the most important thing is 80% of the time the patients will get better. It is the 20% of the time the supportive care that is very important. Most important thing is for the front line, the PPEs is the most important thing. Having an intelligent use of masks, and the most important thing being hand hygiene and social distancing. Mask, hand hygiene, social distancing, all 3 have to be done. And it's not that one is, if you use one, the other can be thing. All 3 has to be strict. And only if you have all these 3, can we actually, break the chain of this particular disease. I think if you have to have a carry home point, be it a doctor, healthcare professional, or a lay person, a hand hygiene, frequent hand hygiene, wearing mask all the time appropriately, depending on whether it's an N95 or a surgical mask or even a cloth mask, appropriate mask for the appropriate situation and the person, and social distancing. These 3 are the watchwords. It's not about the high flowing ventilation, HFNC. No, those are not going to be very important. All these 3 are important, especially this COVID era.
Sir, I would like to say,
Soumya.
so
Soumya, yes.
Now every person, Every person in the world is a COVID PhD. Everybody has got, because of all the WhatsApp messages, they're getting lots of information. Now, this can help in two ways. One is it causes awareness. Another thing is unnecessary panic. So it is really important that the public gets access to the correct information. And also, this is a battle or a disease which cannot be cured by doctors. It is a community force. It's the public themselves who can cure this particular disease or prevent this particular disease. Doctors have very little role to play. So I would advise the community to maintain the discipline in society. That is the most important and effective weapon against COVID-19. Second, for doctors and healthcare professionals, nobody is going to be there to look after our safety. It is our responsibility to look after our safety. As it is, we have shortage of masks, we have shortage of PPEs. So I feel that each doctor should be careful enough for himself and his own family. So these are two things that I would like to impress.
Deepak, you would like to say something?
Just only one thing, let the public not panic. Fortunately, the condition and the number of serious cases, fatal cases are still low. So please don't feel low, keep your immunity high. And one of the best ways of keeping the immunity high is to stay with a positive attitude. Not panic, not get scared. Just because you got a fever or a cough, or even if you became COVID positive, you have 98% chance of surviving that, or even more. Thank you so much.
So I think I'll conclude. Even if the lockdown is over, please continue your good habits. What are the good habits? I say 3H. What are the 3H? One is hand washing, hand sanitizer, and hand off the dose. Then 2S. 2S is, one is social distancing, otherwise stay at home. And the fourth, last one is C, cough etiquette. Whether you cough down or not in 2022 also, you cough hygiene or cough etiquette, you should follow. Good habits to be continued. You wash your hands and you wash your legs before you go home or before coming to the hospital. All these good habits should be continued. And don't watch WhatsApp. Don't look at the WhatsApp. Please talk to your doctor. Talk to doctors, and teleconsultation is the way out now. I think I thank the panelists, Dr. Patabi, Dr. Deepak, and Dr. Soumya, and Juventus for giving us a platform. The American College of Physicians of India chapter is thankful to you. We'll meet all of you once again in the COVID webinar series. Thank you.
Sir,
you
moderated very well, sir. Thank you very much. It was a pleasure.
Thanks a lot.
Thank you, sir. Thank you very much. And also would like to thank all the 2,100 participants who have logged in. And unfortunately, we could not take all their questions. So thank you very much for joining.
Yeah, Soumya, I think the questions will come to me and I will answer them in the email.
Okay.
But not many public are there. Who said public is here? It's not public, not many public here.
I was given the information, some public also are there. So
maybe the Juventus public.
In fact, when you said that, I said, okay, see, I have sent more than 5,000 reminders and mails to my contacts. So most of them, not most of them, all of them are doctors. Maybe 2,100 or some medical representative. Maybe.
Could be.
Sure.
Yes, sir.
Thank you.
But anyway, thank you, sir. It was a very nice session. Really enjoyed it.
Thanks a lot.
And we could manage without Suresh also. If Suresh is there, it would have been better. So we could have talked about rapid tests, and we could have talked about the new treatment and so on and so forth. But we have covered maximum points.
For another day. Yeah.
We needed one more hour. We needed one more hour.
Yeah. I think next time we'll have it more time. And I think we have covered enough and more, no? Including COVID and especially the sneezing and the rhinorrhea, which was very important. In fact, a lot of people have a lot of problems. One of my friends had a tonsillar abscess and he wanted to go to ENT surgeon. The ENT surgeon said, no, he won't look at the patient, and we gave antibiotic. If it has to be drained,
correct.
It's really a problem. So
correct.
I think there are so many issues now.
In fact, all through the pandemic, I had to operate quite a few emergencies because in the fear of corona, you cannot stop doing the basic duty.